Corti, historically, for most oncologists, they always thought about AML as fit, unfit. This is like was almost this dichotomous decision. Either you can cure or you are palliating the patient. So how does this factor in when you're thinking about the genetic landscape? Does that factor into your decisions about the fitness, or how does your thinking has evolved?
I think it matters most in newly diagnosed patients, right? Because in a relapsed refractory patient, it matters most what their genetics are, because we have data, for instance, for FLT3 inhibitors that even if you're fit for intensive chemotherapy, a randomized trial, you're going to do as well or better if you're using a FLT3 inhibitor versus intensive chemo. So in the relapse setting, we prioritize genetics 100% to choose the treatment. In the frontline setting, I think we're still, as an AML community, thinking about, fit versus unfit, but it's blurring. And I think more and more that's going to be the case, where just because you have a physically fit 69-year-old gentleman, but they have a P53 mutation, for instance, you can give them intensive chemotherapy, but they're going to do, unfortunately, they're going to do as well or as poorly, depending on how you look at it, with a lower intensity therapy, so you should be prioritizing that. I think, we'll get into the discussions of getting, NPM1, KMT2A rearrange, all the genetics into the frontline setting to help us, better optimize and individualize frontline treatment. And so I think we need to get away from just 7 and 3 or just HMA.